we're kind of moving away from the PDE and into other files that we have that um, give information that we can link maybe to the PDE that give us information that we might want. So in this case, we're talking about the pharmacy characteristics files and the prescriber characteristics file. So we'll start with prescriber characteristics. This is a database that has been put together. It's from the HIC-IDEA prescriber database. And depending on the years of data that you have, you may have a different ID to link to this data. From 2009 to 2013, it was an encrypted identifier, the CCW prescriber ID, which could be linked to this prescriber database, but it was a created identifier. And then after 2014, they became actual identifiers, so you still use them to link, but it's just a different variable name. And there are bridge files available if you're kind of trying to span those 2 years. This database combines NPPES, which is the National Plan and Provider Enumeration System data. That's organized by National Provider Identifier, or NPI. The DEA administration, so there are DEA numbers that are assigned, and then SureScripts data that this all goes into one. It has taxonomy codes, so you could look at the prescriber and find out which specialty they're a part of. You can find practice location, academic credentials. The prescriber file links to the PDE about 95% of the time, so it's pretty good. If it doesn't link, that's usually because however the prescriber ID was reported on the PDE didn't really correspond to any known format. It wasn't NPI or in the previous years DEA or other identifiers, or just the prescriber ID for whatever reason was not present in the HIC-IDEA database. So for those 5% though, it's not a ton. And then we have, after 2014, we always have NPI. And you could, before 2014, it could have been like a DEA number or a UPIN, different types of provider numbers. So 2013 data and before, you could request a prescriber ID qualifier code, which would tell you what kind of identifier it was. So then you would be able to flag the NPIs. It was still, I think, mostly NPI, but you could have some others. And after 2014, it's universally NPI. The taxonomy codes that they have, like we mentioned, would indicate the practice specialty. If you've worked with Part B data on the carrier file, for example, there is a variable called HCFA specialty code. Those are specialty codes that providers use when they're billing CMS. When they signed up with CMS as a participating provider, they let CMS know what specialty they had. This is not exactly the same thing. So you may find occasionally some discrepancy there. We usually say with the HCFA specialty code or the CMS specialty code, that sometimes is more broad because a provider might be saying, well, I'm really a breast cancer surgeon, but I can do other surgeries. So I'm going to kind of say I'm a general surgeon in order to make sure that I'm able to do other surgeries to describe that. Where these taxonomy codes might be more specific, or they may or may not. So the types of examples, the taxonomy kind of gives a lot of digits that will give you information about what the specialty is. Just to give you an idea of the top specialties that in the 2019 event file, for example, family medicine and general internal medicine, as you might expect. There are taxonomy codes that would indicate nurse practitioner at different levels. Family nurse practitioner was one of the next highest after family medicine and general internal medicine. Then cardiology, there's also taxonomy codes for physician assistants. That was the next highest. And psychiatry was the next highest. But by far and away, over half of the PDEs were prescribed by family medicine or general internal medicine prescribers. So if we're linking the prescriber ID to claims, this is an example of how you might use this information. So Gia had provided this example. She was interested in who prescribed Sovaldi, which is, as you've been learning, a high cost drug to treat hepatitis C. Is it a primary care provider versus a specialist? Because when the hepatitis C drugs first came online, and they still are expensive, they were much more likely to be prescribed by specialists. But then there was a concern that the drugs weren't getting to the people that maybe need them, that are in a rural area. They can only access maybe a family medicine doctor. So there was a program that was put into place to promote primary care. And then she could look at, comparing with state A that has this program versus a state that doesn't have this program. What are the differences in the use? So in order to do that, you can keep the prescriber ID of for example, the first drug fill. These are the decisions you have to make. What happens if you have multiple prescriber IDs? You can look in the data, kind of try to figure it out empirically, or you could just kind of arbitrarily say, I'm interested in the first one because that indicates how the patient first got access to the drug. Then identify the NPIs of primary care providers using the physician NPI and provider specialty from the carrier file. And you could use that in order to create this PCP indicator by merging the two together. So that one would be using the Part B claims. And in that case, they found, I wasn't part of this, differences. And it depended on a state that implemented the program. You could see that the primary care provider percentage of prescribers went up. And whereas a state that didn't implement the program, it did go up, but not kind of in that linear fashion, and it remained lower. So that's one way. So you do have specialty information from the claims. If you're already using claims, you could use that. There's also now this specialty information from the prescriber database, so you can also use that. You could see if you're getting different information from the claims or the prescriber database, kind of how do you want to handle that, but you have options. The next file that we're going to talk about is the pharmacy characteristics file. So again, for the PDE, the pharmacy that filled the data. And generally, the way we have to do it, and I'm guessing the way you will have to do it too, as Becky had mentioned, sometimes our data isn't lined up in the same way yours is, but you use the PDE ID to link to a crosswalk, which will then give you the pharmacy identifier that then you can use to link to the pharmacy characteristics file. So using that, you can get information on what type of pharmacy was it? Was it an independent pharmacy, chain, franchise, government pharmacy? And then you also can get information on the primary dispenser type. Is it from the retail pharmacy, long-term care, non-pharmacy dispensing site? That would be like maybe an emergency room, some place that's, it's not common, but a place that you might get access to prescription medications without having to go up to a desk and hand them your prescription and get it filled that way. Or is it a clinic pharmacy? They have taxonomy codes that will describe these things. You can also find parent organization, and that, just to note, that'll be one parent organization that might correspond to many pharmacy IDs. There's also 340B status. If you might know that if a healthcare organization has 340B status, then they get discounts on medications so that they can provide them for low-income people that just helps them with their prices. And that was, according to this, in the pharmacy file itself, not the pharmacy linked to PDE, that was about 16% of pharmacies. When we link it to the PDE, we found that most of the PDE events are filled at retail or community pharmacies. That's about 77% of the events, but a good percentage are also filled at long-term care pharmacies. And then, even though in the pharmacy characteristics file, there aren't that many mail order pharmacies, as Gia mentioned, the percentage of PDE events that happen through mail order pharmacies has really increased. So we find that almost 9% of the PDE events actually happen through the mail. These are the types of taxonomy codes. It says providers, but in this case, we're talking about pharmacies. So is it a community retail, for example? That's how they would look if you're looking at the taxonomy code, but they do provide the description for you as well. When we want to link this, as I mentioned, to link to the prescriber file, we had in 2006 to 2013 the CCW prescriber ID. And for the pharmacy, we had CCW Pharm ID. Once we move into 2014 data and later, now we have an actual prescriber ID and an NCPDP ID that you can use to link to the pharmacy characteristics file or the prescriber characteristics file. Because we have actual identifiers, you don't have to access them through the CCW, but it is very easy. It's much easier because it just, especially if you're in the VRDC, so you can add that extra file as part of your project without an additional fee. It really helps, you have that one identifier that you can use to link across, and you can get bridge files to bridge these years and then crosswalks so that you can know how those fit together.